yet costs you much. A selfish act brings no lasting value, yet it attracts the enduring resentment of others. A kind word, on the other hand, costs you nothing, and it can bring about a lifetime of value. What if, just once a day, you were to stop yourself before making a cruel remark and replace it with a sincere word of encouragement? Such a thing would cost you absolutely nothing, and yet it would bring real, positive value to your life and your world. Cruelty is a waste of precious time and energy. Kindness is an investment which pays endless dividends. If you desire a life of value, then do things which bring true value, as often as you can. Fill your moments with kindness. So perhaps something we can work on today. Well, thanks again for being here. There are a number of things in front of you today. We'll start out with the $5, what is this, Deb? This is a $5 off coupon for our pharmacy, so we're off of a $10 purchase over the counter. That's great. We have our new provider, our schedule. This has been updated since last time, so we continue to update that when we have more information. The yellow comment cards, you know that we take your comments seriously and we incorporate your feedback as best we can. And finally, if you're interested in winning a door prize, fill out the green slip, please. The prize today is a gift certificate, a $10 gift certificate for our Agnesian Health Shop. So it's real money, so you might want to sign up for that. And over to your right, Deb has set up for us some awesome looking compression stockings. I had no idea they were so fashionable.
Are they
But compression stockings from the health shop. So
They are.
Make sure you stop by that table on your way out. So last August actually, of last year, we welcomed Dr. Alizadegan, who is a vascular surgeon here with Agnesian HealthCare. He comes to us from the Medical College of Wisconsin, but he practices full-time with Agnesian HealthCare through the Fond du Lac Regional Clinic. So that's pretty cool. Full-time here. Thank you for doing that. He joins Jennifer Burgess, who we've all met before. She is our nurse practitioner in vascular surgery, and together they specialize in the care and the surgery of arteries and of veins and treat diseases of the vascular system. So we're very fortunate to have this level of specialty here. I think you would probably agree with that. So Dr. Alizadegan is a graduate of, can you help me with the pronunciation of this? Tabriz University of Medical Sciences in Iran. And he also completed a general surgery residency at the University of Illinois and Iran University of Medical Sciences, as well as his vascular interventional radiology fellowship from the Medical College of Wisconsin. I could take a breath now. He is board certified by the American Board of Surgery as well. So please join me in welcoming Dr. Alizadegan.
Thank you, and thanks for having me here. First of all, I just wanted to say that I like the presentation to be more interactive. I don't have to go through all the slides. If you have any questions or anything that you don't understand, just raise your hand and I will be happy to answer. Peripheral vascular surgery is now a subspecialty. Probably about 40-50 years ago, general surgery was covering all these diseases and all these entities. And vascular surgery, urology, orthopedics were under the umbrella of general surgery. But now they are different subspecialties. And now people have to go through a fellowship or subspecialty training to do peripheral vascular surgery. And in vascular surgery or peripheral vascular surgery, we cover diseases of arteries, veins, lymphatics, and also we take care of vascular access patients. Vascular access means catheters, dialysis catheters, AV fistulas or AV grafts. Also, we treat vascular compression syndromes, meaning that in anywhere in body, if there is a compression on an artery or a vein or nerve, we treat that either by non-surgical or surgical ways. One of the examples of vascular compression syndrome is the thoracic outlet syndrome, when the first strip compresses on the subclavian artery or subclavian vein. And a peripheral vascular surgeon or a vascular surgeon takes care of all the arteries and veins in the body beyond the ascending arch of the aorta. So this area and the heart is a heart surgeon or cardiac surgeon's field. But there are cases that we do together, sometimes thoracoabdominal aneurysms, meaning that an aneurysm or dilation of the aorta that starts at the root of the aorta down to the lower extremities. Sometimes there are cases that we do together because patient needs to go under pump, and that is a cardiac surgeon's specialty and field of expertise. Also, branches of the aorta, these are branches that come up from the aorta, the left subclavian, left carotid artery, right carotid artery, and right subclavian artery. These are carotid arteries, as you know, are the arteries who provide flow to our blood flow to our brain. The main factor that causes problem in our arteries is the atherosclerosis. There are risk factors that many of us are familiar with: smoking, diabetes, and hyperlipidemia, high cholesterol, and hypertension, high blood pressure. These are conventional risk factors, and we all know. There are other predisposing factors like advanced age, or being overweight, physical inactivity, male gender, or perimenopausal women, insulin resistance, family history, genetics, behavioral, and socioeconomic factors that are also considered risk factors for atherosclerosis. There are some conditional risk factors, which is homocysteinemia, C-reactive protein, fibrinogen lipoprotein, and hypertriglyceridemia, which is the different type of high dyslipidemia. Also, there are some other factors like inflammatory markers, infectious agents, and vascular calcification markers that are emerging nowadays, and they're still under research. What happens is in an artery, this is a picture or example of an artery that that we have 3 layers in the artery. One of them is the adventitia, the tough layer under and around the artery, the toughest layer of the artery, and the media that has muscle layer of the muscular layer of the artery, and intima, which is the first layer that is going to be involved in the atherosclerosis. First, you have the initiation of the plaque, means that there's an injury to the intima or inner layer of the artery, and then the plaque matures, and there will be inflammatory cells be involved and cause inflammation, and also the plaque becomes unstable, and then there will be a thrombus or a clot, and this will be very unstable, and it may get detached and send emboli or completely block the lumen of the artery. And this is also the picture of progression of the atherosclerotic plaque. And the same process that happens in coronary arteries happens in the peripheral arteries. There's no difference. It's a normal artery. You have early atheroma, just some lipid and some fatty content cells start forming in the artery, and then either it becomes a vulnerable plaque that builds a thin fibrous cap, and then you will have a large lipid pool, and it will absorb the inflammatory cells, or it may become stabilized, and it may not progress at all if you take the good medication and take the right medication, and you do the good lifestyle change. But if things progress, then you will have a thrombosis or clot formation of the ruptured plaque, and then complete blockage or very tight narrowing of the artery, which causes problem with the blood flow. Now, starting by going, region to the different parts of the body, cerebrovascular disease is one of the diseases that we take care of, and it's mostly involves carotid arteries, carotid stenosis, or narrowing of the carotid arteries. We have one carotid artery on each side. Fibromuscular dysplasia, or FMD, is a rare disease that sometimes we see in carotid arteries. Aneurysms, or dilation or ballooning of the artery because of the weakness of the wall of the artery, or dissections. We have some examples of those that I will show to you. Carotid stenosis, or narrowing the artery of the carotid artery, could be asymptomatic without any symptoms, and most of the time patient doesn't even know that there's a narrowing in the artery. Or it could be symptomatic. Symptomatic means that patient has some symptoms like changes in the vision on the same side, or a transient changes in the motor function or sensory function. For example, a patient comes and tells you that I have weakness in my hand, and it takes a couple of hours, but it goes away. The first thing that you should think of is the carotid stenosis, almost always on the contralateral side, on the other side. And the reason they get TIA is that when you have stenosis of the artery, there is a plaque that is unstable, and a small piece of that plaque gets detached and sent to the brain vessels, but it's not large enough to cause a stroke. It's just transient, and blood is able to provide flow from the collateral vessels. And a stroke is when you have CVA and part of the brain dies. This is a procedure that we commonly use. It's one of the most common procedures that a vascular surgeon does. It's called carotid endarterectomy. Carotid endarterectomy means that when you have this plaque inside the artery, and this plaque is causing stenosis and narrowing of the artery, you want to prevent and reduce the risk of a stroke. This is not done to improve the blood flow, because brain has enough blood flow. Brain is supplied by 4 major arteries. 2 of them are carotid arteries. 2 other ones are vertebral arteries behind the brain. So most of the cases, more than 95% of these cases, just to provide to improve the to decrease the risk of stroke. So what we need to do is to remove this plaque and make sure that the remaining surface is smooth and there's no piece of plaque that is going to embolize or send to the brain. And this is the standard endarterectomy, meaning that we use the patch. Almost every vascular surgeon uses a patch to repair the artery, because if you open the artery and then sew it back again, it's going to be narrower. So we put a patch to improve the diameter of the artery so you don't get stenosis or narrowing. And during this procedure, we need to put clamps on the artery so blood flow through one side that we are operating on will be completely ceased, and there will be no blood flow from that side. That means that, and patient almost 99% of the time will not get a stroke by seizing this blood flow to the brain. It means that there's enough blood flow coming from the other side. There are different randomized controlled trials that were done for to evaluate the value of doing endarterectomy, and they all showed that by doing carotid endarterectomy, you reduce the risk of a stroke significantly, and preoperative CVA or death just relating to this surgery is pretty low and acceptable. Carotid stenting is another procedure that is done in cath lab, and we do it in the cath lab under patient is most of the time awake, just with local anesthesia. Access will be through the femoral artery, which is in the groin, and this is done using catheters and wires. This is a carotid stenosis, which is pre-stenting. It's pretty narrow, and the rest of the part that you don't see in angiogram is the plaque. So, so this artery is pretty narrow, and there's high risk of stroke and emboli. This is after stenting, and you see that the lumen is almost back to normal, and flow, and the plaque is pushed back by the stent. And it has, carotid stenting has its own indications. You can't do carotid stenting for all patients, just all of the patients, because there is some increased risk of stroke, minimal increased risk, and that is not considered standard of care for just a simple carotid stenosis for a patient. This is a picture that shows the stent inside the carotid artery. This is the internal carotid artery that provides flow to the brain, and the other one is external that provides flow, which provides flow to the face. And during the stent placement, there is a technology that we provide in protection to blood flow to the brain by putting a filter here. So what we do first is put a filter to make sure that while doing the stenting, no clot or no particle will be sent to the brain. If there is one, it will be captured by the filter. And then we recapture the filter and bring it down. And probably 1 out of 3 or 4 cases, when we open the filter, there are small particles of clot in the filter. And these are indications for carotid artery stenting. These are patients who we don't recommend doing open carotid surgery, either if the patient is not able to tolerate the general anesthesia, or if the patient has a history of damage to the other vocal cord, because there is minimal risk of a nerve injury during the carotid endarterectomy, something between 1 to 3%. So if the other side, the other vocal cord is injured, if you injure the other, the contralateral side, then patient won't be able to talk at all. So that's why we recommend carotid stenting, because it doesn't involve any cuts or any incisions on the neck. Or if the patient had neck surgery on the same side, means that there is scar tissue, there is inflammation, and it's very difficult to identify nerves and arteries and other structures, so we prefer to do carotid stenting. Or someone who had neck radiation. Actually, I treated two patients with neck radiation, and I had to put a stent in their carotid artery. The neck radiation, the rationale for neck radiation is the same as previous neck surgery. Or if you did carotid endarterectomy, or you did the surgery and patient developed another stenosis because of high cholesterol or other risk factors, then you don't want to go back in there, because you already know that there's lots of inflammation, and you can't differentiate the structures from each other. So it's better to treat the artery from inside. So this is the slide about endarterectomy versus stenting. The risk of primary outcome of stroke and myocardial infarction or death was not different between two groups. But during the pre-procedural period, means that right after the procedure, there was higher risk of stroke with stenting and a higher risk of myocardial infarction with endarterectomy. This means that if a patient is very sick and you think that they cannot tolerate the anesthesia, or high risk for general anesthesia, you prefer to do carotid stenting. And if you have a patient with good overall health, you would prefer to do endarterectomy. This is fibromuscular dysplasia. We don't know why, we don't know the pathophysiology of this disease, but sometimes you see beading of the artery in angiogram, and this is not this is not atherosclerotic. You usually see this disease in younger female patients, and it's pretty common in carotid and also renal arteries. Treatment for this, even though you have stenosis, treatment for this disease is just balloon angioplasty, meaning that we put the balloon inside and inflate the balloon and treat it with just the balloon. Because if you put stent in there, the reaction around the stent will cause worse stenosis, and then the artery may shut down very soon. And this is an angiogram of a patient.
When you do that dilation, do you have to go back and do it then periodically to maintain the opening?
So what we do after any intervention, we do ultrasound surveillance. So first we do it like after 1 month, 3 months, 6 months, and if it stays stable, we just do it yearly basis. If it gets narrower and it becomes tight, then we have to intervene, yes. And how we measure that and how we find out that if it's stenotic is not the size of the artery, it's the velocity at which the blood is flowing inside that segment. Because the tighter it becomes, the faster the blood flows through it. Just like the hose, when you push your finger on it, it jets and it flows faster. This is a kind of common clinical finding that patient comes. I've seen patients. Sometimes I see patients in my clinic with pulsating neck mass, and a few of them were referred to me. And it could be due to aneurysm or dilation of the carotid artery. But most common cause of pulsating neck mass is tortuosity of the carotid artery. Sometimes the carotid artery takes 360 degrees turn, and it's just a cluster of artery there, or there's a kink, just like this is the angiogram of the same patient. Carotid dissection. Let's see if I have another. No, I don't. Sometimes there is an injury. So, as I said, adventitia, media, and intima. These are usually, let's say that this artery's initial diameter was this, and this lumen was this big. Sometimes there's an injury to the intima, and blood, since it has high pressure, will dissect through the layers of the artery. And what happens is that the clot and the blood that was able to get into the layers of artery pushes the artery down and collapses the artery. And this is called dissection, but in this particular case, the carotid artery dissection. So the carotid artery is compressed by blood, dissecting upward from the tear in the aortic dissection. Usually it's upward from the aorta up to the carotid artery. And it may also dissect the coronary arteries and cause the same problem. Treatment for this, if patient does not have any symptoms, is just giving the patient a blood thinner. We don't intervene on them unless there is risk of stroke or patient has symptoms of stroke. And also, brachiocephalic artery is the artery that originates from the ascending aorta and gives off two branches, right carotid artery and left carotid artery. So we don't have brachiocephalic artery on the left side, it's always on the right side. These are different types of the aortic arch. We need to, before doing any intervention, vascular surgeon or a cardiac surgeon or interventional radiologist needs to know what kind of arch is he dealing with, because it will determine what kind of catheter we need to use to get access to any of these arteries. If you have this type of arch, you can't use the catheter that works for this one, because this origin of this artery is from a common trunk, but here is directly from the arch. And some patients have aberrant right subclavian artery. It's an artery that provides flow to the right upper extremity. And it's interesting that this artery, instead of originating from the common trunk here or brachiocephalic artery originates right behind the aortic arch. And this is a cross section of that artery, the aortic arch that comes behind it. And one of the problems that may cause is dysphagia. Patient comes with initially presents with the inability to swallow, and most of the tests are normal. Swallow test is normal, but then when you do a CT, you will see that there is an abnormal artery originating from the aortic arch and compressing the esophagus. It's the esophagus, and this is the trachea or the windpipe. Also, sometimes we take care of complex repair of aortic arch diseases. When this is a graft that is sewn to the artery proximally and distally, and also we need to provide flow to the branches, so we need to make bypasses of the aortic arch to provide flow to the carotid arteries and subclavian arteries.
That slide back. Wouldn't an esophageal manometry catch that compression?
Manometry, well, barium swallow may show it, yes. You can see indentation of this, but manometer, I don't know.
Okay.
It may. That's a good question. I don't know.
See
You should be able to see it, yes. We are still talking about upper extremity. This is the aortic arch. Heart is located here, and flows this way. Subclavian steal syndrome. This happens when you have narrowing of the subclavian artery, and when you do any activities with your arm, well, muscles and tissues of the arm are asking for more blood flow and oxygen, but there's no blood flow coming from the proximal or the origin of it. There's a branch which is called vertebral artery that is still attached to the subclavian artery. What happens is that because the resistance of blood or resistance of the blood flow on the arm decreases, instead of the blood flow, instead of going up into the vertebral artery, it becomes reversed, and this vessel, instead of providing flow to the brain, provides flow to the arm. That's when patient becomes dizzy and symptomatic. So when a patient comes and tells you that when I work with my arm or do some workout, I just get dizzy and I can't do it anymore, it means that he or she has steal syndrome. So direction of flow in vertebral arteries should be this way, always toward the brain, but it becomes reversed. One of the treatments for that is carotid subclavian bypass. So we make bypass and get the blood flow from the carotid to the subclavian to solve the problem, or we can do transposition, meaning that we completely detach the artery from the arch and attach it to the carotid artery. Sometimes we need to make very complex repairs of the aortic arch, and it involves both open and endovascular, meaning that this part is an endograft. This is a covered stent that is covering this aneurysm. You see that this large area, we need to seal that and cover it, but at the same time we need to provide blood flow to other branches. If we leave these open, retrograde blood flow from these arteries will fill the sac, and this is gonna keep growing until it ruptures. So we need to, first of all, seize the blood flow to this sac and then tie it up and provide blood flow to the distal. It looks more like a plumbing. So, when we are planning to treat a vessel for any occlusion or aneurysm or any stenosis, there are some lesions that are more favorable to intervention. Intervention means something that is done in the angiogram suite or cath lab under X-ray without making any major cuts or major incisions. If you have only a stenosis or narrowing the artery, it's favorable to intervention. You can put a balloon inside and then dilate it. Or there are concentric lesions, or they are non-osteal lesions. Osteal lesion is when you have a narrowing right at the origin of the, let's say that this artery was, let's say that this was stenotic. If there was narrowing over here, you don't want to do intervention, or you don't want to put the balloon in, because if you rupture this artery will be completely detached from the aorta and will be catastrophe, and patient will die right away. Or the lesions or narrowing of the artery that is not calcified, it's just soft, soft plaque, or if they are not non-ulcerated, meaning that they are not unstable. If you do intervention on it, you will detach a plaque and send it to the distal. If you have total occlusion, meaning that the artery is completely down and there's no blood flow going through it, it's very difficult to get through that, because the instruments and wires are designed in a way that the tip of our catheters, tip of our wires are very soft, because we don't want to injure the vessel. And if it's total occlusion and it's calcified or eccentric, you can't go and get through it. If there's lots of tortuosity or rotation of the vessel origin, you are controlling it from the groin, like the angiogram, and it's very difficult to go through it or guide your wire through the artery if this is very, very tortuous. If there's calcification, ulceration, and symptomatic lesions like carotid stenosis, or patient has TIA or CVA, or lesions near the vertebral artery origin, like the one that I showed before. Sometimes, the most common access site for intervention is the femoral artery in the groin. But sometimes we need to get access to the brachial axis, which is easier, and we just get access to the arm, to the radial, and put the balloon in and treat the lesion. This is a list of the conditions that we have in vascular surgery, and for example, one of them is intermittent claudication, is when the patient comes and tells you that, well, after a certain distance, I get pain in my calf and I can't walk, and I have to rest for 5 minutes, 10 minutes, and then I can keep walking. This means that patient has very severe occlusion of the arteries in lower extremity. Or sometimes there's a venous claudication, meaning that there is bursting pain, and also there's engorgement of veins of the lower extremity, and because of the heaviness and bursting pain that the patient feels in lower extremity, he can't walk. Or compartment syndromes. Compartment syndrome is when you have high pressure inside the compartment that contains muscles, nerves, and veins, and it's a limited space due to fracture, due to intra-compartmental bleeding, for example, an arterial injury, or a snake bite, or some crush injuries. You get swelling inside the compartment, and that swelling pushes on other structures, which one of them is the vein and the artery, and that compression seizes the blood flow to the rest of the compartment, and you need to release that by fasciotomy. Aorta and large artery pain usually is due to dissection or hematoma, or aortic rupture, or vasculitic inflammation. Sometimes patients get aortitis, meaning that they get inflammation of the aorta, and the treatment for that is not surgery, it's just medication and steroids. Let's go to intermittent claudication. This is a very common scenario in our patients, and most common reason for referral to vascular surgeons. They usually get calf, thigh, or buttock pain after certain distance of walking, and when they rest, pain goes away. The distance is always the same. They say that, well, I can't walk more than 50 yards, and the distance is always the same. The ankle brachial index is the measurement of blood flow. That is a non-invasive test we do. It's always abnormal in these patients. Pain is not constant, and when they are at rest, they don't have pain. There's no tissue loss. Tissue loss meaning any wound or anything, any darkness, redness of the abnormal redness of the tissue. And it's either because of inflow disease or outflow disease. Inflow disease means that there's obstruction or narrowing of the flow, arterial flow above the inguinal ligament, above the groin. Outflow is anything below the inguinal ligament. This is an example of inflow disease. This is this is aorta, which bifurcates, and you have the common iliac artery here. You see the blockage here. This is an example of inflow disease, which is inguinal ligament is located here. So each one goes to each leg. This is outflow disease. You can see the femur bone. Is it femur or any? Yes, it should be. And there's occlusion of this artery here. And you see that there are some small collateral arteries forming to be able to provide flow to the distal, but usually they are not good enough to provide flow for the activity. Critical limb ischemia, lower extremity gain. This is when your patient has rest pain, means that she wakes up during the night and complains of severe foot pain, leg pain, and it doesn't go away until he or she walks and takes pain pills, which usually doesn't help. Or there's gangrene, meaning that tissue loss. You see that the tissue is dying here and there's no blood flow to it. And mostly it's on the forefoot or the heel. And they represent with the reduction in distal tissue perfusion below resting metabolic requirements. So in claudication, blood flow is enough to provide flow to keep the leg or foot viable, and they do fine when they are not doing anything. But in these patients, it's very critical, and the blood flow is not enough even for the resting requirements of the tissue. Ankle pressure is less than 50 millimeter of mercury. So if you put a cuff around the ankle, your blood pressure is going to be less than 50 millimeter of mercury, while the systemic blood pressure might be 150 or 120 or 120 or 80. Toe pressure is less than 30 millimeter of mercury. There are special cuffs that goes around the toe, and you can measure the toe pressure, and they are less than 30 millimeter. And ABI, or ankle brachial index, is less than 40. That's when you get critical limb ischemia. And there is difference between intermittent claudication, the first case scenario, and critical limb ischemia. So if patient comes with intermittent claudication, you still try, we try to treat them non-surgically. Means that if they don't have inflow disease, we just, what we tell them is that, first of all, you need to quit smoking. That's the main thing for them. And then they need to start a walking program, in that they keep walking at a lower pace until they start getting pain, and then after they get rest and pain goes away, they start walking again. This helps to form new collaterals. The vessels that are blocked already, they will not recanalize. but this will form new collaterals through the artery. And there are patients which are successful with this and they don't need an intervention. And interestingly, patients who have intermittent claudication, risk of amputation on that limb is less than 5%. Over 5 years means that you still have time to do non-surgical management for these patients. And going and doing something crazy about their vessels that may hurt them, because you may cause problem with that collateral flow that was already there. There's a group of these patients, intermittent claudication patients, who are diabetes or have very low initial ankle brachial index or high pack years of smoking. They progress to ischemic rest pain, meaning that they fall into the critical limb ischemia. But when patient gets to the critical limb ischemia, they have high risk of major amputation and death. So when someone has critical limb ischemia, it means that all the reserve of the body and to form new vessels and bypass that stenotic areas are done, and most of the time you're not able to do a bypass or offer something more. And out of these patients, 20% of them will be dead in 5 years. 40% of them will be alive, but with an amputation, and 40% will still be alive without amputation, but functionally their lifestyle will be changed significantly. Aneurysms is the dilation of the artery. This is another entity that it may happen in any artery in the body. And we have two different types of aneurysm, fusiform and saccular. It was, in the past they used to believe that saccular aneurysm have higher risk of rupture, but recent studies did not show that. There are different types of aneurysms: degenerative, inflammatory, post-dissection, traumatic, developmental, and infectious. Degenerative is the most common one. These are the ones that we see in cath lab and treat them. The AAAs are mostly degenerative. This is an inflammatory aneurysm. You see that this is the contrast inside the artery. This is a CT angiogram. Contrast or dye inside the artery, but this tissue that you see around it is just inflammation. It's inflammation around the artery. The treatment for this is not surgery. This needs, risk reduction and also prednisone and steroids and anti-inflammatory agents. This is an infected aneurysm because you see air around or in the layer of the artery. This dark spots are air. This is a very bad situation, and this part of the aorta or graft or whatever it is needs to come out. This is a dissection, means that the blood got access into the layers of the artery and dissects through the lumen. You should have only one lumen here, but it formed another lumen, which is a false lumen. And what happens in this, because this part doesn't have all the layers of the aorta, it starts enlarging and becomes an aneurysm, degenerative aneurysm. We do endovascular repair of aneurysms, thoracic aortic aneurysm, TAA is the abbreviation for that, or abdominal aortic aneurysm, AAA repair, iliac aneurysm, and visceral aneurysm. I have repaired few thoracic aortic aneurysms here, and probably more than 20 patients with AAAs, and few iliac aneurysm, and I didn't have any visceral aneurysms here, but it usually is surgical if you can't seal them. This is how the EVAR, the one, this is for descending aortic aneurysm. What you do is put the wire in the groin and you get access, put your catheter up and the endograft comes up and you start deploying the endograft. You need to have enough seal zone here to seal this from inside so blood flows through the endograft instead of going into the aneurysm. And this part, over time, gets absorbed and aorta remodels, what we call it, remodels. After a couple of years, if you get a CAT scan, this part doesn't exist anymore and it just sticks to the aorta. This is an intraoperative picture of the endovascular repair. We have the wire that the device is guiding our device, and this is the catheter for the angiogram, and this is after. This is before deployment of the graft. This is how it looks during the procedure before deployment, and this is after deployment, and it seals that area. So this is the difference between what happens in endovascular and open. In endovascular, you get access to both groins, and usually the device is 2 pieces, sometimes 3 pieces. You deploy it, and then you cannulate this gate, and you seal from inside, and all you see is 2 1-centimeter incisions in the groin. Actually, I fixed one 7-centimeter aneurysm last night, and he was in the ICU, but he's doing okay. This is open when you need to get access to the aneurysm by making incision and opening the aorta and sewing the graft to the aorta. And after we put the graft, we need to put the balloon to make sure that and dilate the graft with the balloon to make sure that it's sealed. Open aneurysm repair, intraoperative picture. This is from internet. This is not my case. These are stitches. You will have stitches up in the aorta, right below the kidneys, and also in the groin. So overall, there was no. So when you compare open versus endovascular repair of the aortic aneurysm, there was no significant survival benefit for endovascular strategy versus open. Well, when you open aortic surgery is a big deal. Patient stays in hospital sometimes 1 week, 10 days, 2 weeks, more, maybe more. But overall, in long term, there is no survival benefit. Meaning that they survive at the same rate. But there was gains for endovascular strategy versus the open repair in respect to patient preferred outcomes, meaning that patient wants to go home faster. They want to move to home. And quality of life is better, and overall the endovascular strategy is cost effective because the device in endovascular repair is sometimes, I don't know, maybe $10,000. But the cost of the patient staying in hospital with all the nursing care and devices or medication that are used in 7 days, and then rehab, and then they may get a stroke, and then everything adds up to it. So it's cost effective to do endovascular repair in patients if they are suitable case. And all the patients who undergo endovascular repair need to be monitored, and we need to have a surveillance for them. Because if anything goes wrong with the graft, you need to fix it as soon as possible. EVAR requires imaging on a yearly basis, and there is risk of endoleak. Endoleak is something that is specific for the endovascular repair. There are 4 types of them, and it's when you don't have a good seal on each side. Again, plumbing problem. You don't have a good seal, distal or proximal, and blood flows around it, and this keeps getting larger and larger until it ruptures. Or there is a vessel that is still attached to the sac of the aneurysm, and it's back bleeding into the sac. This is type 2. Type 3 is when your graft is not good. This type is type 3 is when you have bleeding between the attachments of the graft. So there's an overlap here between these two pieces, the main body and the extension, and it bleeds and makes the aneurysm larger. Or the graft has porosities, and some patients, by unknown reason, the fluid leaks through that over time. It takes like 5-6 years. This is pretty rare nowadays because the grafts are made of 7 to 9 layers, and it's pretty rare. This is visceral intervention. Sometimes we have patients who come with the narrowing of the visceral arteries which provide flow to the gut, to the colon, to the small bowel, and the intervention here shows the catheter and the stent that is placed in the superior mesenteric artery. And usually patients who have severe stenosis of visceral arteries, they come with lack of appetite. When they eat, they get pain and they lose weight. So you think about visceral narrowing or stenosis. And this is a filter that it's optional to use in these because you don't want to send the emboli when you are doing intervention. You can put the filter here and put the intervention and take the filter out, like the carotid, just like the carotid. Venous disease. Actually, we are getting many venous disease referrals, mostly because of the wounds, and usually the reason behind venous disease is a DVT or a clot that forms inside one of the veins, and it destroys the valves. When there's no valve inside the venous system, the flowing veins is toward the heart, and there's a valve to prevent the backward blood flow toward the gravity. But when the valve is destroyed, the blood comes in and out, and all the weight of that column of fluid puts pressure on the lower part of the leg. That's how you see these wounds. And venous ulcers, it's not very difficult to differentiate them differentiate between arterial and venous. Venous ulcers have, first of all, they are usually on the lower leg, and they are hyperpigmented. They are darker than the other areas, because what happens in venous ulcers is that the fluid and blood leaks into the tissue, and you know that we have red blood cells inside in our blood, but the fluid gets absorbed. The most of the proteins gets absorbed, but the iron that is in hemoglobin stays there, and this is the hemosiderin, or a compound of iron that sits there for almost forever. But in arterial ulcers, you don't see hyperpigmentation. Usually they are around the toes, or you have loss of tissue, and usually the limb is white or whiter and pale comparing to the venous ulcers. For venous stasis ulcer, we need to know the underlying pathophysiology. Is there just a varicose vein, or is there some problem with the deep venous system, or is it just a wound that is because of other medical conditions? First, what we do is compression therapy. Even without doing intervention, many of patients get relief with compression therapy, which is those stockings that they have there. Almost every patient gets one of those. And then we start doing reflux studies too. We want to find out if there's reflux, if the valve is competent or not. If they are not, then we need to do something about the vessel. And before doing any intervention, we need to know if the arterial blood flow is enough to heal the wound. If not, then we fix the artery first and then go after the vein. Then we ablate incompetent veins. There are so many different ways to do it. It's RFA or injection of the sclerosing agent or ligation. Sometimes I have to take that piece of vein out to disconnect it from the distal part. And also local wound care and hygiene is very important. So this just explains the function of the valve in the vein. The direction of flow is always this way, and when you get incompetent veins, this is what happens to the vein. Blood flow comes in and out, and you get tortuous veins along this length of the vein, and you need to do something about it because the pressure of the branches of this vein will be on the skin, and most of the pressure is put on around the ankle and lower part of the leg. So as I said, laser ablation, RFA ablation, sclerosing agent, there are different types of medication that could be used. Microphlebectomy is when we just make very small few millimeter incisions and just take the vein with a special hook. And sometimes we ligate and divide, or stripping is an old method of treating it. They used to just take the whole vein out, the greater saphenous vein from the groin to the ankle. It's not being done anymore because it was a pretty morbid. Sorry, it took longer than was expected. Any questions? I'll be happy to.
I saw that slide where the anatomical differences between the branches off the aorta. Do you find that, given all of the same risk factors, that there are some patients more prone to some of your vascular diseases given a certain anatomical structure of the aorta?
That's a very good question. I never thought of that, but it's, I don't know, because not in terms of like occlusion and aneurysms, but some patients, for example, some anomalies like subclavian, aberrant subclavian, they form aneurysms at the ostium of the artery. But no, the one type that all three vessels come up from the same trunk is called bovine arch, which is pretty common, but intervention on those is more difficult than other those. I don't know, to be honest.
I was just curious for
Yeah.
a screening.
So if you were to have like a young trauma patient that had either a carotid dissection on one side or bilateral carotid dissection, like over time, does that ever heal or is that repairable at all?
Over time, the dissections, if they are not progressing, what happens is that the thrombus inside that, or the blood clot inside the layers of the artery gets absorbed. And we need to monitor that artery because if the artery's wall becomes very weak, it may become aneurysmal. Then we need to treat it. But for the dissection itself, no, we don't need to do any intervention. Most of the time it gets absorbed, and in maybe a couple of years you will see the artery very close to normal.
In terms of preventative screenings for a younger person, just a normal average person, what indicators do you look for to see if you're predisposed to any of these conditions?
There are well-known risk factors, like for example, for different diseases like aortic aneurysm. Let's say hypertension is a known risk factor. Smoking, whoever who had more than 100 cigarettes during lifetime is prone to aortic aneurysm formation. High cholesterol and anatomical anomalies, family history is very strong in aortic aneurysm. In carotid disease, hyperlipidemia, high cholesterol, smoking, most of them come from the degenerative changes in the artery, which is atherosclerosis, the same risk factors. Okay.
Thank you very
Thank
much.
you.
Have you pick our winner.
I thought everyone gets one.
We also have an extra prize.
No, but
Okay.
Sarah Klutsky. Did I read it right? Oh.
Excellent. Thanks for being here today, and remember to invest in kindness today. Have a great weekend.
All right, thank you.